Hello, everyone, and welcome to another GoggleDocs post-conference review. This time we're looking at the ESC Congress, the European Society of Cardiology, which recently concluded in Barcelona this year. And I'm proud to say we're joined by, of course, Patrick Holmes, my fellow GoggleDoc, but also Claire Davies, a specialist pharmacist in diabetes and endocrinology. Hi, both.
Hi, thanks for having me.
No problem at all. So, I guess the interesting thing with this is the European Society of Cardiology is the first ESC since the pandemic. So 3 years now, and I was there, fortunately, and it was palpable, the excitement and the interest of being in a face-to-face conference, as we're well aware of now. Fortunately, in diabetes, we've had a few now. But it was good to see the cardiologists also kind of get that excitement. And whilst this is a cardiology-specific conference, the lines of cardiometabolic disease are blurred. So there's definitely a lot of diabetes, renal disease, and risk factor management. And I guess that's what we're going to be talking about today, really. We're going to be focusing it from a more cardiometabolic angle. And I'm going to ask my colleagues just a bit about their key take-homes or their one data bit or trial that they found most interesting. So guess first, Claire, what was your take-home from this?
So probably my biggest take-homes from ESC this year was the SECURE trial, which was to do with a poly pill. And this was to do with secondary prevention for cardiovascular disease in people over the age of 65. So as we all know, people come in, might have an MI, go home on a boatload of pills, and adherence is not great on those boatload of pills. That's really interesting from a pharmacy perspective because they've looked at how to concoct this tablet so that the pharmacokinetics are not affected. So you've got your aspirin, your atorvastatin, and your ramipril in one tablet. They monitored 2,500 patients over 7 countries post-MI and looked at their primary endpoint was reduction in cardiovascular death, MI or stroke compared to standard care, so getting those tablets separately. And they had a 24% risk reduction, so quite significant. And what was also interesting, as you're saying, is that this is post-COVID. So these trials were done during COVID times, so a lot of people lost to follow-up, weren't engaging as much with potentially with contact points, and they still had quite a significant reduction. But really the take-home point for me is, what does this mean for us in the future in terms of how we manage people's medicines, not just in cardiovascular disease, but also in diabetes? Are we going to be able to put more tablets in one pill? Is that going to improve adherence? And is that also going to improve tablet burden and things like carbon footprint and environmental sustainability as well, if we can do it? So that's my take home. Will it change what I do? Maybe it will. Maybe I'll think more about combination products and how that improves compliance and adherence for patients.
Interesting. I want to actually pick up on that you mentioned. So Patrick, I think, certainly speaking locally as well, the usage of polypills or combination therapy, even in diabetes, from my area of interest, is not quite frowned upon, but it's not really used as often. I never understand why. Why is probably UK a bit hesitant with regards to that?
I think it's to do with training. I mean, the interesting thing is, if you go into Northern Ireland, they're the same as the rest of the UK in terms of using individual pills. But you go over to over the border into the Republic of Ireland, they're completely different. They do use combination pills, and so does the rest of Europe. So we're the odd man out here, and it has to be said, it's something I do use combination pills, but it's frustrating on a practical basis that often the pharmacy won't have them, or it'll take longer lead times. And then if there's a supply problem, patients are being bounced back. So it's hardly encourage you to prescribe these combination pills. And I've been told for years by pharmacists, well, you can't adjust, you can't tweak this, you can't tweak that. So we've got a pharmacist on the call here advocating a polypill. So I think we should, I think, Claire, you're for Prime Minister now. Get rid of Liz Truss. We'll have you because I think that is the way forward. Because I think, as you say, it's a real challenge. If you've got someone with type 2 diabetes, they've got heart failure, they've got osteoarthritis, maybe taking some painkillers, and they've got CKD, and we throw a whole bunch of pills at them, and it makes me sad, and we can see that clearly people aren't taking the pills. I don't think there's something magic having in the pills. The reality is we know that not everybody's taking the pills. So if we can combine it, I think it seems to work. Maybe we need another trial. We'll come on to another trial which perhaps says it's important to have more than one trial before we make decisions. But in terms of the polypill, of course, we have had other trials. It's just the fascinating thing is the usual care is in a European setting. It's not in Iran, where I think another one was done. So this is relevant, I think, for the UK. And I would agree with Claire. This should change our practice. We just need the tools now to be able to prescribe them.
I was getting jumpy when you... Sorry, go on, Claire.
I was just going to say, if we think about this from a diabetes perspective, I'm not sure I'm going to start combination pills all the time, but they're definitely going to be more in my mind. There is still that little thing in my head about titration. And if somebody had a problem, how would I know what drug had caused the problem? And how would I convince that person to go back on that agent if it's all been in one tablet? But maybe if I'm having people in clinic and I'm starting to think about adding another tablet on and they're talking about their tablet burden, maybe I say, well, and I know I have done this in clinic last week, can I try this tablet? And if you're stable and you're comfortable, I'm going to then switch you to a combination once I know you're stable and you're happy on it. And that will reduce your tablet burden overall.
Excellent. Yeah, and I agree with that. And I would kind of say some medications have different side effects that you could probably differentiate between, but I will leave it there. A few nuances about that trial, but again, this is the headlines. We can talk about it in more detail at another time. Patrick, you gave us a little kind of tasty little bit of a morsel of something that you were going to mention, so I'd like you to go and tell us your highlight.
So it's a very aptly named trial, this one, and I'll remember this name of this trial. It's the time trial. So this is asking the question, do you take your blood pressure pills in the morning or the evening, or does it not matter? And it's a much larger trial. So the bit of background on this, there was a Spanish study, I'll try to pronounce the name, but I'll get it wrong, which is the Hygieia chronotherapy trial, which was done in northern Spain, published about 3 years ago now. And again, there was a big thrust. There was a big push for this because there was this amazing reduction of about a third reduction in the two arms. So the people who were taking at least one blood pressure pill in the evening were getting this benefit compared to people who were just taking them in the morning, or that's what we were told. And there were one or two issues which came up about perhaps the trial. So, but locally we certainly adopted it. And then lo and behold, this trial comes along. So what did this trial show? It showed really no difference, no statistical difference between when you took the tablets. I think the actual numbers was there was a 3.4% reduction event rate if you took it in the evening, whereas 3.7. But that wasn't statistically different, and it's a very marginal difference there. So I think it then goes back to what the patients want. We know it's a challenge to take multiple doses. I mean, my bête noire, of course, is the metformin 3 times a day. That really winds me up. But this one, I think it gives us the opportunity, particularly if we're using, newer generation statins. They can take a lot of their pills perhaps just once a day, which makes it easier. And also it fits into that, perhaps the polypill as well. So it's all that space, and I think it makes it easier for patients to take their medication, and and that's all we want, because if they don't take the medication, it's not going to work. So this is great, and it changes my practice because, well, I was sort of sucked into that other trial, and I think it shows you the importance of needing multiple trials. Certainly the time trial in terms of size and scale dwarfs the older trial. So I think this is now the new standard.
I remember.
I don't know. What did you think, Claire? From a pharmacy perspective, is this something which is going to change your practice, or were you never sold on that other trial anyway?
I think, do you know what this has reiterated is that we know there's no real difference now in what time. So let's go back to first principles. The best medicine that someone's going to take is the medicine they're going to remember to take, and they're going to take because it works for them at the right time with their lifestyle. And also in terms of once a day, the other great thing about that is if you forget, you still have time to take it again later in the day. Whereas if it's at night time and you forget, you've missed a dose by the time you wake up the next morning. And we've talked about that. The polypill talked a lot about adherence, how many doses do people miss. So I think it doesn't massively change my practice, but it does make me a little bit less worried about having to start a blood pressure tablet at night, because I was always told, well, if you're going to drop your blood pressure, you'll do it when you're asleep and there's no risk. Now I'm told that's probably rubbish.
I think it should show, a true 24-hour effective pill is what we want, rather than timing of day you take it or so. The other thing about this is the safety signals of this as well. When they took it, there was no increased risk. One of the key kind of worries sometimes is taking it at night, that postural hypertension, the drops, the falls. But again, there was none of that signal. So again, fairly reassuring either way from that. So so I'm glad we had you on this, Claire. We got 2 pill-based and pharmacy-based trials that are relevant. I'm going to actually talk about something that's slightly different. It's more a kind of a discussion that I found quite interesting. So it was about this at risk of diabetes or pre-diabetes, and it was a session looking at cardiovascular risk in that group. And we know, a lot of observational and epidemiological data shows that people who are at risk of diabetes or pre-diabetes, as we call it, are higher risk of cardiovascular disease and events. And I think what the gist of the trial was really when someone's diagnosed at that pre-diabetes state, they're already at a high cardiovascular risk. And almost we're looking at I know this is not quite controversial, but a pre-diabetes state where, when do we act? And that's a whole can of worms. But I guess it's kind of saying, and I got thinking, is the term pre-diabetes, when we use it, kind of a bit too glucocentric? We have this 42 to 47 millimoles per mole cutoff for HbA1c, where we do, put people into these trials and prevention programs. But it's not just the glucose; it's actually the cardiovascular risk and the LDL cholesterol, the blood pressure. And are we missing a trick by just looking at the HbA1c and focusing on that, and of course the weight? I'm interested to hear both of you or either of your thoughts on this, because I think that really got me thinking about, I guess, what we need to be doing maybe more in a population-based setting. Patrick?
Well, I mean, for me, it's all, yeah. I mean, we've already got the model in the sense type 2. So is pre-diabetes just a baby type 2 diabetes? Because the whole issue about where we take the cutoffs and define complications, of course, the cutoff for diabetes was based on retinopathy. And even we know that's probably not quite as robust in terms of the exact cutoff. So I think for me, we've for years we've been too glucocentric when it comes to diabetes, particularly type 2 diabetes, and so it's we need to take the learnings from that type 2 diabetes and just move it down to people a little bit earlier on in the pathway. So we definitely should be looking at cardiovascular risk and really only looking to treat beyond the glucose for sure, and we need to be definitely looking at cardiovascular risk reduction. So obviously things like statins come into play, even though we know they increase the blood sugar, because actually we're not that bothered about the blood sugar, and that's a conversation I often have with, we are bothered about the blood sugar, but less so. It's only a modest increase. What we are more concerned about is what they're going to essentially die of or be harmed by, and they tend to be cardiovascular events. Certainly, that's the one which we can intervene and make a biggest difference. So it doesn't. For me, I'm already there, but I think for a lot of the people we treat, they're looking from a glucose perspective, and in truth, I think a lot of HCPs look at that. In terms of the national screening program for pre-diabetes, a lot of these are in NHS health checks. Unfortunately, certainly locally, the NHS health checks are quite clearly looking at cardiovascular risk assessment. So that's been done at the HbA1c, because in some of the discussion, because I did see some of the discussion, quite clearly there were some people just focusing on the glucose, and they weren't actually looking at that broader cardiovascular risk. But yeah, so it's not going to change my practice. But I think it was interesting as a thought piece. I don't know about yourself, Claire. What was your take home on it?
I agree with all of that. I think my take home is it's coming back to that language matters and how we have these discussions with people, because they'll come in and they'll have that screening and we'll say your HbA1c is higher than we would like it to be, and everything they see in the media, in the news, everything is about glucose, about sugar tax. And all of a sudden they'll then come back in and that number will be low, and we say you've done great, but we're going to give you a tablet. And they'll go, but the tablet doesn't lower my sugar. Why are you giving me this tablet? Statins are a perfect example. Or maybe a cardiovascular risk disease drug, for example. And they'll say, but I've done everything you've asked me to. We need to start those conversations earlier about what we are treating and what our risks are, and the fact that this is not just a sugar disease, as we're calling it, or glucocentric, because we need to change that. But that also needs to change out in mainstream media and in what's coming out and what people see on the telly, in the news, on the front of their paper, because they're not seeing you might get a tablet to reduce your risk of something else. They're seeing things about their weight and things about what you put in your mouth and what you're paying for your Lucozade, for example. So that's the difference. We have to change that bit as much as we can as healthcare professionals as well.
Yeah, I think that was my take home, is that changing that to the whole risk factor management, risk discussion, rather than just focusing on one thing, definitely. So I just want to end really with, I guess probably for me, the key trial. The reason I went to ESC was because of this trial, and actually it was a good one. So it's the DELIVER trial. So dapagliflozin, an SGLT2 inhibitor, Already we've had actually alternatives showing benefit in hospitalization for heart failure. We had the recent Emperor Preserve looking at HFpEF as well. But this is the dapagliflozin's turn, and this was a really well-conducted trial that looked at people with heart failure with a preserved ejection fraction, so over 40%. And majority of them actually were, they had cutoffs of between less than 60 or over 60 as well. So they had a good range of people with preserved ejection fraction, and it was looking at effect of dapagliflozin in that group. And I guess what we all wanted to see was kind of shown in a way. It did show benefit in HFpEF. So in people, regardless of ejection fraction, less than 60%, over 60%, there was benefit for dapagliflozin in terms of the composite endpoint of hospitalization for heart failure and cardiovascular mortality. However, it was largely driven by hospitalization for heart failure. On top of this, the trial had a number about 11 publications in total at the end of it, a lot of data coming from it. But really, we can talk left, right, and center about the heart failure side of things, but I guess I want to bring it to ourselves. And what does this mean now in the setting of diabetes, potentially type 2 diabetes, where we use it a lot, but now with heart failure, where we're using it in reduced ejection fraction? What does that mean for our patients in heart failure? Bear in mind, empagliflozin already has a license in the UK now for heart failure, no mention of ejection fraction. Go, anyone can come in first. I'm interested to hear your thoughts. Ladies first.
I guess it'll be me then.
Okay.
So I think it makes life simpler. I think for me, I think it also shows the importance actually of other conditions. If we're looking at type 2 diabetes, of course, the vast majority of people are going to be on SGLT2 inhibitors. So we've got to get it right, because we're actually treating them before they even develop the condition. So one would expect that we're probably postponing clinical presentation at the very least. So that's really important. And of course, for people who don't, who have already got established heart failure, it makes it a lot easier to do the searches. I'm not having to look for a whole load of ejection fractions and go back, and because we're time short in the NHS. So this will make it a lot easier to implement. So I suppose that for me, it just makes life simpler. It's always, I suppose the unanswered questions I do have though is are the improvements in quality of life meaningful? Because that there is a difference between the placebo and dapagliflozin was better, but they're relatively small. So the numbers needed to treat are going to be small, particularly when we're really, because the patient, I suppose, is saying, what's in it for me? You give me another pill, because it's not in a poly pill yet. So you give me another pill. Yes, it's going to keep me out of hospital. I think that's obviously a really good thing, and I think most people would do that. But it would go for that. But outside of that, really, it's the hope of improvements in symptoms, which is difficult to measure, and the cardiovascular benefits in terms of mortality weren't quite there. Although it was seen in the other study, so Emperor Preserved. So in a sense, I suspect if we had bigger numbers, it probably does have a small cardiovascular death benefit, but that's speculation on my part. So I suppose the magnitude of these hard outcomes is small, but going into hospital, I think, particularly when COVID's around and you've got heart failure, I don't think it's a good thing. Claire, you work in a hospital, so I suspect you would concur. But what was your thoughts about that study?
So I think a couple of things. So I'd agree it makes it easier. We've got an effect across the continuum of heart failure now, and it didn't have that same attenuation that we thought empagliflozin might have. So we don't have that need for a repeat echo, searching for an ejection fraction anymore. We have a blanket drug we can use. I agree still, if you're going into hospital, you're acutely unwell, or with COVID, these are not the best drugs. We should still hold them off. But I would add to that, interestingly, Deliver did initiate DAPA in people who were in hospital, which we hadn't seen in Emperor Preserved, and still had good outcomes. So that also gives me confidence that this is a safe drug to initiate in hospital, get it in early. You're in a monitored place. We can keep an eye on you. It's one of the safest places, arguably, we could start these medicines if we are worried. So that did make me think this is good. We can get this therapy in earlier for a wider range of people. What I'll be interested to see from a UK perspective is, how does it get badged? Currently, we have for HFpEF, it's specialist initiation. What do we do now? This is going to now open the floodgates, but we have a larger indication now. Does it need that specialist initiation anymore? I don't know. Question for the masses. I'd be interested to see what NICE do.
It's interesting, yeah. So and licensing will be key as well, kind of when it does come in. But I just wanted to actually I think we're kind of done that. But I just wanted to mention, Patrick, was there mortality benefit with Emperor preserved? I thought it was still hospitalization for heart failure.
I think with cardiovascular death, overall mortality wasn't improved. So that's my recollection. I did look at the paper just earlier on today, just to be certain of that fact. So because I'd forgotten about that there. Obviously, it was the primary endpoint was combined, but there were fewer cardiovascular deaths.
Excellent.
You're gonna have to cut that out, of course, if I'm right.
There we go. So I was going to check. But thank you. Yep. So we've heard about the TIME, SECURE trial, about pre-diabetes and cardiovascular risk, and of course, DELIVER. Looking forward to discuss further things because we've got ESD coming up shortly. So I'm sure there'll be a lot more further to discuss to continue the discussions around all these treatments that we mentioned. And I just want to thank you both for being here and look forward to seeing you again in the future. Thank you.
Okay.
Pleasure.
Bye-bye.